Hi all, welcome to the OSCE section. So in this OSCE section, we are discussing about rheumatology. As we know, rheumatology has lots of images, lots of multi-system disorders it has, right? And when we broadly divide rheumatology, we mostly divide it into the three main categories. First is our connective tissue disorders, right? In which we have the common examples like SLE, rheumatoid arthritis, Sjogren syndrome, right? Even systemic sclerosis. So these are some common examples we discuss in the connective tissue disorders. Then second one will be myositis, let's say muscles. Okay, myositis in which we have the dermatomyositis, polymyositis. Okay. Then third one would be associated with the vasculitis. Okay, vasculitis. In vasculitis, again, we have three main examples depending on what type of vessels are involved. So if the large vessel vasculitis is there, we know giant cell arteritis is there and Takayasu arteritis is there. If medium vessel vasculitis is there, then Kawasaki is there and Pan is there. Okay, polyarteritis nodosa and Kawasaki is there, right? And if you talk about the small vessel vasculitis, in small vessel again, depending on the ANCA positivity, if it's P ANCA, we have granulomatosis polyangiitis, and C ANCA, we have EGP, like eosinophilic granulomatosis with angiitis, EGA, and also our MPA is there, HSP is there. Okay, so these are all included in the ANCA positive vasculitis, right? So now, when we talk about the arthritis per se in rheumatology, arthritis, it can be of two types. We all know. One will be seropositive. Seropositive. Okay, seropositive in the sense the RF factor is positive. Okay, RF factor is positive. And one predominant example will be rheumatoid arthritis for them. And when we talk about the seronegative arthritis, okay, seronegative, I will just change the ink. Yeah, seronegative. Just a second. So yeah, seronegative. So when we talk about the seronegative arthritis, we have 4 to 5 examples. So mostly they affect the peripheral. So in that also we have two things. First is axial. So we call it as a spondyloarthropathies collectively. Spondyloarthropathies. Okay, spondyloarthropathies. It can be axial, that means only involving the spinal cord, or it can be, only vertebrae, and it can be peripheral also, where it involves the peripheral joint. Okay, so when we talk about the axial, we have ankylosing spondylitis. Angspond is there, very, very important. And when we talk about the peripheral, in peripheral, first we have is, let's start with the reactive arthritis, psoriatic arthritis, right? Then we have IBD associated arthritis. Okay, IBD associated arthritis, right? IBD means inflammatory bowel disease like ulcerative colitis and all, very commonly associated with the arthritis also. That can call as like other manifestation, okay, or extra intestinal manifestations of the inflammatory bowel disease. Okay, apart from that, one more syndrome can come over here as a SAPHO syndrome. Okay, SAPHO syndrome, that is synovitis, acne, pustulosis, hyperosteoarthritis, osteosis, and osteoarthritis. O is for osteoarthritis. Okay, SAPHO, don't worry, we'll discuss it again. So these are few things that are included in the peripheral. Okay, so reactive is there, psoriatic is there, IBD is there. Yes, apart from that, we have some crystal arthropathies. Okay, crystal arthropathies like gout and pseudo gout. That also we're going to discuss today. Okay, so we will go more over in the image format because this is the OSCE discussion, and our prime focus is to make you sure that you know all the images. Most of the time, you know the theory, but you just get confused with the images itself. Okay, so our role is to identify the image, then write down the features of that image, and then maybe ask or like answer some systemic questions. Okay, so yeah, let's start with the first one. As we can clearly see over here. Yes. What do you think? We can see the joint deformities is there. Okay. Here, joint deformity is there. There is a flexion at the distal interphalangeal joint. And similarly over here, you can see there is an extension at the distal interphalangeal joint and flexion at the proximal interphalangeal. So they are completely opposite to each other. And this is the, you can see there's a deviation of the hand to the lateral side or ulnar side, what we can say. Okay, so this is nothing but rheumatoid arthritis features, deformities. Okay, so this disease is nothing but rheumatoid arthritis. Now we know how does rheumatoid arthritis occur. It's a chronic autoimmune inflammatory polyarthritis, very important, and it basically affects your synovial membrane, thinking that it's a foreign substance, like it's an autoimmune reaction. That's why, and creates antibody against that. And gradually, what happens when there is a destruction of anything, there is a development of new thing. So new bone and I mean new synovial membrane or new inflammatory cells gets formed over there. And if it is not treated properly, that immunosuppression grows, that immune reaction goes, okay, grows, and that can lead to the deformities of not only joints but also bones. That's why rheumatoid arthritis treatment is also equally important. Basically, that's why it is called as disease modifying agents. Okay, DMR, disease rheumatoid arthritis, we have already discussed, right? So now let's start with the one thing at a time. So this is how the swan neck deformity is, in which there is a flexion of the distal interphalangeal joint. Okay, so that is the swan neck deformity, very important for us. Now, second is this. This is the bottinia deformity. As we can see, there is a proximal flexion and distal hyperextension. Okay, so this is nothing but the bottinia deformity, another feature of the rheumatoid arthritis that we have to know. There is no excuse for that. If you don't know this basic swan neck deformity, bottinia deformity, then maybe you are not even an MBBS person. Okay, because in medicine, Viva and all everywhere it is asked in the UGs as well. So we can't make mistake in this, right? Then this is little tricky when it comes to exam. You just get confused. Oh God, what it is a Dupuytren contracture? What is happening over here? But look at the history also. Most of the times, MCQs or in asking questions also, the history is quite clear. So they must have given over there. Otherwise, you can just make it out considering the age of the person and the lateral rotation of the hand like this. So this has to be ulnar deviation of the hand, also called as Z deformity. Okay, Z deformity, right? Z, I don't know why it's called as Z, but like this, we can make it remember like that. Okay, so Z deformity. Okay, Z deformity of the RA. So these are few important joint deformities that you have to know in the rheumatoid arthritis. Rheumatoid arthritis is not only about the joint, we all know. It has multiple systems, starting with the eyes itself. Okay, scleritis, it can cause scleritis, it can cause in the lungs, it can cause inflammatory, your interstitial lung disease. In heart, it can cause my carditis is associated with this. Okay, myocarditis is with rheumatoid arthritis. Even pericarditis, very important for rheumatoid arthritis. In any inflammatory disease, pericarditis can happen. Okay, even pleuritis and all can also happen. But the important factor is in rheumatoid arthritis, there is also increased risk of cardiovascular worsening of the patient. Because the coronary artery disease also is a high in case of rheumatoid arthritis, that we have to know. Apart from that, skin finding, if asked, they have, so you have to see about this rheumatoid nodules. Okay, so these are small rheumatoid nodules over here. They are painless, and usually this nodule get ulcerated. Okay, nodules will lead to ulceration, and that ulceration will lead to necrosis. Okay, that ulceration will lead to necrosis. Now, whenever there is a necrosis and all, anything, like obviously that tissue may fall off, but the important point is this is painless. And one more important point is it is usually seen, strongly seen, if the rheumatoid factor is positive. I mean, if rheumatoid factor is positive, RA factor is positive, there is a high chance that patient might have the rheumatoid nodules also, so we have to check that. Right, that's for the skin finding. Now coming to the radiology. So in radiology, there are few important things in the rheumatoid arthritis, because there is a joint destruction occurring. Okay, so normally this should be the joint space, and like this is how it appears normally. Now this space is called as periarticular. Periarticular, why? Because that is near the articular surface, or that is near the joint, periarticular. So the most important finding in the rheumatoid arthritis, as we can see over here, this cortical thinning is there. Okay, near the joint, that is called as periarticular, okay, or juxta articular, okay, juxta articular osteopenia, osteopenia. Okay, juxta articular osteopenia is the very important finding, one of the important finding, right? Apart from that, we are seeing that there is a joint space narrowing over here. Okay, so that is also one more feature. Joint space narrowing is there, and one more thing over here, we can see this type of bony spurs can be there. Okay, here also you can see. So this is a marginal syndesmophytes that can be seen in case of RA. Okay, so these are the three important findings that you should never miss whenever we see the patient of rheumatoid arthritis. I hope I'm clear, right? Moving onward, we have the systemic findings of rheumatoid arthritis. We have already told about that. In eyes, you can get in ocular, you can get keratoconjunctivitis, scleritis. If it's a nerve involvement, you can get neuropathy. Cervical myelopathy can also occur. In lungs, you can get interstitial lung disease. In heart, you can get pericarditis, myocarditis, even endocarditis. Dermatological rheumatoid nodules can be there. Sometimes vasculitic rashes can also be there. Hematological neutropenia can be there. Okay, so Feltis syndrome is one condition where there's a triad of RA plus SLE plus splenomegaly. Okay, splenomegaly. So these are some features of rheumatoid arthritis that you have to know, right? I hope I simplified it for you. Now coming to the diagnostic criteria. For diagnosis, it's very easy. We apply a criteria, basically that's called as clinical classification criteria for rheumatoid arthritis, and we have the mnemonic for that. So whenever you get OSCE or whenever you get rheumat case in your vivas, you are just sad. Okay. So just sad is the mnemonic. J is for the joint involvement. Okay. So joint involvement, how many joints are involved? So depending on that, okay, if one joint is involved, then zero. Okay, if one large joint is involved, if multiple large joint is involved, then score is one. If more than 10 large joint involved, then score is five. Okay, so remember, joint involvement has the highest score for the rheumatoid arthritis. Coming to the SAD. So S is nothing but serology. Serology means the antibodies. If RA factor, okay, which is literally an IgM against the IgG. So RA factor and anti-CCP antibody, if they are positive, score is 1. If not, then score is 0. Simple. Then A is for the acute phase reactants. Acute phase reactants. Okay, acute phase reactants, what are those? ESR, CRP. Hana? We all know about this. ESR, CRP. These are acute phase reactants. So obviously, in rheumatoid arthritis, this will be high. If it is not high, score is 0. If it's high, score is 1. And then D is for the duration. Yeah, D is for the duration. If duration is more than 6 weeks, it's a chronic, score is 1. So rheumatoid has to be a chronic inflammatory polyarthritis, right? So that's the same thing what we discussed. Joint, just SAD. Okay, so joint more than 10, score is 5. Serology, if high positive, both of them, score is 3. Okay, acute phase reactant, if both of them are abnormal, then score is 1. And if the duration is more than equal to 6 weeks, then score is 1. And total score of more than 6, more than equal to 6, labels the patient as a rheumatoid arthritis. Clinical classification criteria for the rheumatoid arthritis. Okay, I hope it's very easy for you. Coming to the management now, rheumatoid arthritis is diagnosed now. Management, we will start with the disease modifying agents. So what are those? Methotrexate is a drug of choice. Okay. Along with that, we have alternate DMARDs like leflunomide, hydroxychloroquine, sulfasalazine, and some biologicals are also used nowadays. Biological DMARDs like TNF inhibitors, adalimumab, etanercept is there, commonly used Recept. Targeted DMARD is also very commonly used, like JAK inhibitors, tofacitinib, baricitinib. Even corticosteroids like prednisolone can be used if patient is not getting better, the symptoms are not improving. NSAIDs for the symptomatic pain relief and the surgery if there is an erosive type of arthritis. Okay, so this is in a nutshell for the rheumatoid arthritis that we have to know for the OSCEs. Now let's start with the spondyloarthritis. So as I mentioned, in spondyloarthritis, two things were there. First was axial spondyloarthritis, second was peripheral arthropathies. In axial spondyloarthritis, what we had is the ankylosing spondylitis. Now, in ankylosing spondylitis, it's very easy again. It's basically HLA-B27 related type of arthritis. Here also the autoimmune reaction will be there against the vertebrae. Okay, as it involves only the axial joints. So it will involve the vertebrae. And whenever there's an involvement of the vertebrae, we know because of inflammation, what will happen again? The new bone formation, etc. will happen. And at the same time, the sacroiliac joint is also involved because it is close to axial only, axial skeleton only. So sacroiliac joint is involved and the entire vertebrae, all the vertebrae are involved. Because of this, what happens? Whenever there's an inflammation, let's say these are the two vertebrae. Okay, this is little rectangular. They are more kind of square like this. Okay, yeah, yes. So whenever there's an inflammation over here, what happens? there's a newborn formation. Okay, newborn formation occurs. So because of this newborn formation and all, okay, this is again called as syndesmophytes. Okay, these are also called as syndesmophytes over here. And because of this, there is a reduction in between the two vertebrae. And because of this, the stiffness occurs. Okay, because of this, the stiffness will occur. And the spine will appear fused, vertebrae will appear fused. Okay, but the spinal process of the vertebrae will appear fused because of this. And also this vertebrae looks like a bamboo, and this spinal processes looks like a dagger because of this. Okay, like a dagger. No? Suppose this is the 3D structure. Just imagine this is the dagger is. Okay, like this. We have an image for that also over here. So see over here, the healthy spine, the inflammation of the joints is there, and here also the inflamed spine is there with the reduction in the disc space. Here you can see the vertebral shape has changed, the box shape. The spinous process are fused like this, giving this dagger-like appearance. And the appearance of the vertebrae is like a bamboo, right? So it's called as bamboo spine appearance. Okay, bamboo tree, bamboo spine appearance. It's very classic for the ankylosing spondylitis. Along with that, they might give image like this also, or they might give image like this also, like where the eyes are involved. It's basically anterior uveitis. Okay, anterior uveitis. So uveitis is also called as iridocyclitis, right? Because there is an inflammation of the iris as well as ciliary. Okay, so anterior uveitis is also associated with the ankle sponge. Along with that, you can see the sacroiliac joint is involved. So because of this, there are multiple symptoms in the ankle patient. Number one would be early morning stiffness. Okay, morning stiffness in the vertebrae, very important. Morning stiffness is there. Okay, then along with that, the buttock pain is there. Okay, buttock pain is there. Okay, so these are few important, and some extra articular features are there, which we just discussed. Extra articular features are also there. Okay, in the form of uveitis, etc., interstitial lung disease, all that can also happen with the angst also. Okay, so it's also a multi-system, and rather than, yeah, multi-system, or we can say poly system disorder. Okay, so for angst we have two things, two tests, small tests. One is called as Patrick's test. Patrick's is Faber. Faber is what? Flexion, abduction, and external rotation. So whenever there is involvement of the sacroiliac joint, we ask the patient to Faber. Okay, Faber. That is, we flex at the hip, then do the abduction, that means moving out, and do the external rotation like this. Whenever you do this and patient is having pain, there is sacroiliac joint involvement. Okay, so this is how the Faber is done. Look at this. Okay, flexion is done over here. Then abduction is done, and then external rotation is done. Okay, so that is your Faber, very important. Now moving on to the Schauber's test. Schauber's test is also done for the angst. Basically, we have to keep two distance, 2 points basically, one at the level of the thoracic, one level of lumbar, and the distance should be 10 centimeter. And when someone flexes, there is an increase in the spinal length by around 5 centimeter. That means the distance will become 15 centimeter if somebody flexes the spine. But if they're not, if they're having angst, this increase in the length will be less than 5 centimeter. Okay, it will be less than 5 centimeter. That gives us that the spine is fused and the patient is having angst. Okay, the diagnosis of the angst is clinical most of the times. You have to confirm with the HLA-B27. Okay, HLA-B27 is positive in 90% of the angst patient. And very important thing is, angst as such does not have any treatment. Yes, there is a role of some immunomodulators in this, but as such, no. Initially, NSAIDs can help in the initial phase, but gradually the patient does not respond to even NSAIDs also, and the pain is persistent, stiffness, symptomatic relief is quite difficult to give in the angst. Okay, so obviously the immunomodulators, biologicals are developed, but meanwhile you make sure the patient has a proper physiotherapy and all. That's all is the important for that. Okay, so this is how the extra articular manifestation of the angst can appear. So here we have the uveitis involvement. Okay, at anterior uveitis is there, plus morning stiffness, pain and restriction of the movement along the spine. Sacroiliac joint involvement will be there. Oligoarthritis can occur. Enthesitis is also a very important feature. Okay, enthesitis means where there is a connection between the bone and tendon. Okay, that part is called as enthesis. Okay, so especially at the Achilles tendon. This is very important point. Okay, Achilles tendon. This is very, very. I have seen a classic patient of the enthesitis recently only, and I posted about that also. Okay, so vascular cardiac involvement is there, inflammatory bowel disease, IgA nephropathy, and chronic prostatitis. So all these things come together in this patient and make the diagnosis of the angstpon clinically. So for diagnosis, again, we have one more clinical criteria, and that's very easy to remember actually. So whenever you have angstpon, just we look for the two things. First is MRI showing sacroiliac joint involvement. Okay, if MRI showing sacroiliac joint involvement, we just need more than equal to one feature. Okay, more than equal to one feature. Like what are those features? Enthesitis or uveitis. Okay, or pulmonary involvement. Right. So all these measured symptoms in the angstpon. But if there is no MRI involvement, only serology is positive. Serology means your HLA-B 27 is positive. Now, in this case, you need more than equal to two symptoms. Okay, more than equal to two symptoms. What are the symptoms? All those symptoms. Let's see. I hope you understood, right? MRI, that is called as a radiological wing and serology wing. Okay, so let's see this. In radiology, if MRI is positive, then you say it's a sacroiliitis. And if it is HLA-B 27 positive, then you have to look for all these symptoms, and at least two or more than two should be there. Okay. Yes. So here we go. What are those symptoms? Inflammatory back pain, arthritis, enthesitis, anterior uveitis, dactylitis, finger pain, psoriasis, Crohn's disease, because all it is also with the autoimmune disease. Good response to NSAIDs, it's a good thing. Actually, history of SPA, family history of SPA, sorry, HLB27 and elevated CRP. So all of these things will be pointing towards the ankylosing spondylitis. Now, coming to the approach to other seronegative arthritis. So, as I said, other seronegative arthritis, the main and important one starts with the reactive arthritis. First, we have reactive arthritis, then we have psoriatic arthritis, then we have IBD-associated arthritis, then we have SAPHO. Okay, yes. So here we have the first one, that is famous reactive arthritis. Okay, reactive arthritis, as the name suggests, it occurs due to the reaction to some sort of infection. If patient is having urinary tract infection, if patient is having viral infection. So in after all these cases, like just chikungunya, you can take dengue, you can take. After all this, reactive arthritis can happen. Okay, so reactive arthritis usually occurs after the urethritis or UTI also. So that's why it has the classic triad of ACU. Okay, A is for arthritis, C is for conjunctivitis, and U is for the urethritis, ACU. Apart from that, there are very important skin classic features that can be seen in the ACU. First, starting with the eyes, scleritis can be seen. Conjunctivitis, obviously, it's seen as been saw in the triad. Then arthritis is also there. Okay, small joints are involved. Peripheral small joints are involved in this. Okay, very important. Then your glans penis is involved. Okay, glans penis is involved, called as balanitis. Okay, glans is involved, that is called as balanitis or cercinet balanitis. Okay, balanitis or balanitis cercinet. You can see cercinet balanitis cercinet. Okay, depends on the like this depends on the language, Italian and all. Okay. Yeah, so glans is involved, arthritis is occur. Now, sometimes the feet is also involved. At the feet, there is an increase in the keratin or the keratoderma, what we say that. Okay, so that is called as keratoderma blenorechica. Okay, blenorechica. Keratoderma blenorechica. So these are some classic features. Apart from that, there are skin features. Okay, so let's see that now. Okay, even the subingual keratitis is there. Yeah, subingual keratosis is there. Okay, keratosis. Right. Yeah. So reactive arthritis is there, ACU is there, arthritis, conjunctivitis, neurarthritis. Plus, it will involve the glands, it will involve the feet in the form of Clearderma blenorechica, and also involves the nail bed causing subungual keratosis. Okay. Yes. So here we see the images. First, triad conjunctivitis, arthritis, blepharitis, conjunctivitis. Okay. Then urethritis, balanitis. Okay. Then subungual keratitis over here, joint involvement because of arthritis. Then this type of skin involvement called as keratoderma blenorechica looks really bad, but it gets better. Okay. Yeah. Then enthesitis is like a group symptom of the peripheral small arthropathies. Okay. So that is very and even for seronegative arthritis, any seronegative enthesitis can be there. Okay. Then This soft palate ulcers can also be seen in this patient. Okay, that's about reactive arthritis. So for reactive arthritis, what we do is the symptomatic management. Just give patient some a bit lignocaine jelly vagara for the oral ulcers and the genital ulcers, and most of the time, as the infection subsides, this gets better. Coming to the one more seronegative arthritis now, which is very commonly asked in exams. Okay, even not like in OSCE, they'll ask in the theory, not in the theory, they'll ask in the vivas. So it's very, very important. Okay. So that is nothing but your psoriatic arthritis. Okay. Psoriatic arthritis. Okay. Just a second. I'll just put the charger. Huh? Yeah. Okay. Yes, we're all set. So yeah, we are talking about the psoriatic arthritis, commonly asked question. Now here, remember, whenever patient has a psoriasis, okay, or if patient is having arthritis, in psoriatic patient, almost 20 to 30 percent patients can get into the arthritis. Very important fact. Okay. Now here you can see whenever someone is having psoriasis, obviously skin features will be there. But apart from that, what happens in the arthritis? So arthritis again does not only involve the joints. It involves typically the small joints of the hand. Okay, distal interphalangeal. DIP involvement is quite common over here. Okay, small joint is involved, and again it's a erosive type of arthritis. Okay, it is a erosive arthritis. That means just like rheumatoid arthritis, it also erodes the joint. Okay, it's a erosive arthritis, and because of this, what happens? Dactylitis happens. Dactylitis, that means inflammation or pain of the distal interphalangeal joints, or destruction of the distal interphalangeal joints that can occur. Okay, so that's a dactylitis, and that typically gives the appearance of pencil in cup deformity. Okay, pencil in cup deformity. Okay, like this. So this is like basically a cup. Okay, this is basically a cup, and this is how it appears, the pencil. Okay, so I'm sorry for my drawing, but I'll show you in the X-ray. Don't worry. Okay, yeah. So these are features of the psoriatic arthritis, what we just discussed. So it can have dactylitis like this. Look at this big inflammation of the distal interferon joint, so big, right? In size. Look how big is this. Then talking about the peripheral arthritis, look at this peripheral arthritis. Okay, that can also be seen, right? Then enthesitis, as I mentioned, it's a group symptom. Then nail involvement is also there. Nail pitting is quite classic for psoriatic arthritis. Okay, the skin involvement can also be there. And this is psoriasis basically. This is psoriasis. Silver flaky appearance. Then this is the axial spine involvement basically. These are the again pitting of psoriatic arthritis. Nail pitting is there. And finally, this is the X-ray appearance. This is the distal interphalangeal joint involved and destruction of that part. And this gives rise to, look at this, this gives rise to penicillin cup deformity. Okay. Yeah. This gives rise to this penicillin cup deformity. So this is nothing but your psoriatic arthritis. Again, we need to manage this with the immunomodulators, and the patient's outcomes are little questionable because once the joint is eroded, there is a very less chance that it can completely get back. Okay. Right. Coming on to the some other type, but before that, just let's again go through this. Okay, so sometimes onycholysis, nail pitting can occur, X-ray changes. We discussed already penicillin cup deformity. Psoriasis can be there, arthritis mutulence can occur, and enteritis. So this is psoriatic arthritis, which we already discussed. Now coming on to the next type of inflammatory arthritis. This arthritis typically is seen in patient of inflammatory bowel disease. Now again, inflammatory bowel disease does not restrict themselves only to the bowel. They cause the extra intestinal manifestation, as we know. So what are those extra intestinal manifestations? So it can affect the eyes, it can affect again the lungs, it can affect the gallbladder, it can affect the liver, causing steatosis. So let's just go through that quickly. Okay. So in eyes, episcleritis uveitis is very common. In mouth, aphthous ulcer, Crohn's disease, very classic. In liver steatosis. In gallbladder, sclerosing cholangitis, very common for the ulcerative colitis. Okay, and the gallstones can also be seen. Joints, it can involve all the joints. Okay, mostly peripheral. Then phlebitis can also be seen. Pyoderma gangrenosum and the erythema nodosum. Okay, so these are some typical skin features that can also be there. Apart from that, Kidneys can be involved in the form of renal stones, hydronephrosis, fistula, UTI. Okay, so these are some genetic symptoms. But overall, you know that this is also a multi-system disorder of the inflammatory bowel disease. If patient comes to you with if they give you colonoscopy images, okay, if they give you like colonoscopy images of any disease, let's say any disease that we don't know, okay, if they give the colonoscopy images, if it's like rectum and all is shown in that terminal ileum is shown, then it's a Crohn's disease. If they're showing this transverse colon, the extent is there and it is not intramural, then it's the ulcerative colitis. Okay, so colonoscopy images, if it is there, plus these signs are there, then you have to think about IBD-associated arthritis. Okay, HLA-B27 can also be positive in here in few cases. Okay, but it's not very specific, right? Coming on to the now in the new section we are moving on. That is SAPHO. SAPHO is rarely asked, but can be asked because it has lots of clinical features also. Okay, so synovitis, acne, P is for pustulosis, H is for hyperostosis, and O is for osteitis. Okay, okay. Synovitis, acne, pustulosis, hyperostosis, and osteitis. All are caused by the interleukin 17 as an inflammatory modulator. So here we can see how the pustulosis occurs. Okay, this is all pustulosis we can see. And after treatment, it appears like this. And that's what they've given, small images. But you can expect acne, etc. All are the images they have given, and osteitis is also seen. So then we have to think about this. Coming to the one more very important disease over here. Okay, this is commonly asked in the exams, and more importantly, it is very favorite for the rounds and even vivas. It has been more like many times it has been asked. So let's see this. Yeah. So the first one is this. Look at this. There is a node at the distal interphalangeal joint. Okay, here also you can see there is a node at the proximal interphalangeal joint. Okay, if you talk about this, there is a narrowing of the narrowing of the joint spaces is there. Here also narrowing of the joint spaces, and patient had to do the knee transplant over there. Okay, so what do you think with all these findings? This is nothing but a diagnosis of osteoarthritis. Okay, osteoarthritis is a degenerative type of arthritis in the older population, mostly involves the large joint, but it can also involve the small joint. And in small joint, very important 2 points that you have to remember is some nodes are associated with this. Nodes in the sense because of degeneration or bony growth, these nodes can appear. So what are those? If it occurs in the distal part, okay, if it occurs in the distal interphalangeal joint, DIP, then that is called as Heberden's node. Okay, Heberden's nodes. If it occurs in the proximal interphalangeal joint, like here, okay, this is PIP, and this is DIP, right? So this will be Heberden's and P will be Bocard's. Okay, I'll just write down the name. Bocard's. Okay, yeah, Bocard's nodes, right? So this is what you have to remember about the osteoarthritis. Can be asked in the vivas and all basic stuff. Now, how do we manage? Obviously, we manage with the proper physiotherapy to the patient, symptomatic relief. As such, no treatment. Like obviously, knee transplant can be done, but in medical treatment, as such, not because it's a degenerative condition. Okay, so they can also show this type of osteophytes. We can see the bony projection. So that is also one more thing that can appear over here. Coming on to the new topic, that is again crystallopathies, very important in rheumatology. In crystallopathies, we have two things. One is gout and second is pseudogout. Commonly, gout is caused by uric acid depositions and pseudogout is caused by uric acid crystals deposition. Pseudogout is caused by the calcium pyrophosphate deposition. Okay, so uric acid, we know mainly it gets involved into the, mainly it involves the toe, great toe. Okay, so here also in this case, the left great toe is involved, and that is called as podagra. Okay, and the condition is called as gout. Apart from that, when we do the microscopy, first when we do the X-ray, we get the joint erosion is there. Okay, so joint erosion is like this in this patient. Okay, can you see this? The joint erosion is there, and whenever there is a microscopy discussion on this, so at that point, it's very famously labeled as negatively for birefringence. Okay, negative for the birefringence, right? So that's very important for the gout. When we talk about the pseudogout has the rhomboid shaped crystals. Okay, and that is basically positive for the birefringence. Okay, positive birefringence in the microscopy. That's basically like fluorescent technique. Okay, so that's basically pseudogout in the rhomboid shape. So make sure you diagnose that in your viva. Okay, so here you can see this is a needle shape. Okay, needle shape. It's also important. Needle shape. Okay, needle shape. And here you can see these are rhomboid in character. Okay, yeah. Birefringent is two types, right? Yes. Apart from that, in pseudogout, you can get this type of finding over here. Okay. So this is called as chondrocalcinosis, one of the finding for the pseudogout that we can know. Okay. Coming on to the vasculitis component now. Okay, in vasculitis, we have 4 5 component over here. And after that, we'll discuss SLE, relapsing polychondritis also. Okay, so in vasculitis, they will directly give you the exactly features what will happen. So if you have giant cell arteritis, they will give you the temporal artery. They will tell the scenario. If it's a Takayasu arteritis, they will give you the image of the heart. Okay, they will give you the angiography. Takayasu arteritis I've discussed in the CVS module. And then if they have uh, polyarthritis nodosa, in polyarthritis, they will give you the kidney, they will give the image of the vessels, and they will show you some nodes into that because the name itself tells polyarthritis nodosa. If they talk about the Kawasaki disease, in Kawasaki, young kid will be shown with strawberry tongue, some rashes. They will tell the history of 5 days. Okay, so all this will be pointing towards the Kawasaki disease. If they talk about the other vasculitis, ANCA-related vasculitis, so in that only Churg-Strauss syndrome is which is relevant. So in that Churg Strauss also they will give you the palpable like this. Okay, so this is basic out like idea that you can get into that. But if you're talking about the Behcet's, this is again so Behcet's they can show oral genital ulcer. Okay, that can also be there. Yes. So whenever you have this type of palpable purpura, the history is the kid, renal function is disturbed a bit, then the diagnosis will become HSP. Okay. Here, if the patient has this type of skin features, okay, so this is nothing but your uh, livedo reticularis. Okay, with this purplish color of pigmentation is called as livedo reticularis. It is again seen in the pan and SLE. Okay, so in pan polyarthritis nodes, this can also be given along with some vascular images within nodes in it, polyarthritis nodes. Okay, so these are some important things that you should know about the vasculitis. Apart from that, in medium vessel vasculitis, as I mentioned, in polyarthritis nodosa, the small skin changes will be there given. But apart from that, the image of the heart, the vascular involvement will be given, and kidneys are the most commonly affected in this patient. So they have to give this. Apart from that, they will directly tell that the patient has a medium vessel use or medium vessels are affected. Okay, so GTPK. GTPK is basically Gujarat Titans. PK is for Punjab Kings. Gujarat Titans is the large vessel. Punjab Kings, that is Pan, and Kawasaki is the medium vessel. That is. Then, as I mentioned, for Kawasaki, young kid will be shown image of the coronary artery aneurysm. The tongue image is there, strawberry tongue and all is there. Okay, red eyes and fever history for 5 days. Okay, so all this will point the diagnosis towards Kawasaki disease. You can see this. Okay, so this is basically Kawasaki disease, and aneurysm is seen in the coronary arteries. Okay, coming to the older population now, this is how the temporal artery will be shown, and obviously the diagnosis will become giant cell arteritis or temporal arteritis. Okay, and how do we manage this with the steroids and make sure the patient does not get blindness? We have to start steroids before that. Second important thing, temporal artery biopsy is the investigation of choice for the GC or giant cell arteritis. Right. Coming to the very important topic, SLE 9:1 is the female to male ratio is very common in the females. Mainly, they will present with the uh, mainly they will present with the skin manifestation or some vague symptoms like fatigue, weakness, menstrual irregularities. Okay, this can be complained and you diagnose SLE. So that's very common. And but this photosensitive rash, okay, a malar rash is very common. Okay, so this is photosensitive malar rash for the SLE, as we can clearly make it out. Along with that, there is a non-cicatrizing, that means non-scarring alopecia is also there. Apart from that, SLE can have n number of the symptoms. Lupus nephritis can be separately. Okay. Then they can give you about the various blood investigations in the leprosy about sorry SLE. I'm sorry. In SLE, they can give you about the speckled appearance on the immunofluorescence of the anti-DS DNA. Okay, so all these are helpful for you. Yes. And if patient is having this type of cicatrizing, okay, little scarring is there also here also at this lesion. So this is nothing but discoid lupus erythematosus, DLE. Okay, DLE. Okay, so these are some immunofluorescence images. I just was explaining this. So Homogeneous, SLE, DLE, and rheumatoid arthritis, homogeneous appearance. Very, very important. Now, in this, remember RA more because speckled is more SLE. Okay, and also the scleroderma, but for scleroderma, we have nucleolar more common. Okay, so please remember this. And more important than that, if patient has peripheral appearance of this immunofluorescence of the antibodies, basically autoantibodies, then that is a CREST syndrome. Very, very important. 100% one question will be there from this topic. Okay, so we can see this is kind of homogeneous type of anti-TS and low complement C3, C4 is seen typically in SLE patients. Okay, apart from that, we have new condition over there. If you look at this skin, okay, skin is quite thick over here, okay, quite thick and inflamed skin is there. Here also you can see the face, the mouth cavity is closed, okay. Here also you can see the skin is involved a lot. So this is a sclerodactyly. Yes, sclerodactyly. And this is what happens after the you touch to the cold object. That is your Raynaud's phenomena. Okay, Raynaud's phenomenon. Raynaud's phenomenon. Now, sclerodactyly Raynaud's phenomenon, you know, the disease has to be nothing but systemic sclerosis. Okay, systemic sclerosis. Apart from that, these are also the few things. You can see the calcium deposition in the around the joints, right? This is nothing but called as calcinosis. Calcinosis. Okay, here also you can see this type of calcinosis is there. Okay, so till now we saw calcinosis, Raynaud's phenomenon. Okay, we didn't saw esophageal dysmotility. It is seen in the your endoscopy. Esophageal dysmotility. Okay, then S is for sclerodactyly, which we discussed, and T is for the telangiectasia. Telangiectasia. So this is but nothing but your CREST syndrome. Okay, this is nothing but your CREST syndrome, CREST features of the scleroderma, systemic sclerosis. Now, if SCL70 is positive, SCL70 is positive, this is systemic sclerosis. And if anti-centromere, SCL70 have the nucleolar pattern. Which one? Nucleolar pattern. And if anti-centromere antibody is positive, centromeric pattern is there. So that will be definitely your CREST or localized scleroderma. Okay, localized scleroderma or limited scleroderma. Okay, so this will be the scleroderma important features. Okay, so here also you can see this type of anti-SCL70. Okay, nuclear pattern. Okay, now coming to the therapies. So therapies will be, we have to give immunosuppressions, antifibrotic therapy like nintedanib, penicillamine can be helpful for the lungs. Vascular therapy can be tried because there is a risk of vascular narrowing and all in this patient that can also worsen. Then cardiac therapy like calcium channel blockers can also worsen in this patient. Okay. Yes. Coming to the second last topic over here, uh, you can see the glands are involved in this patient, right? Multiple glands are involved over there, right? So this is nothing but the Sjogren syndrome. Okay, this is nothing but Sjogren syndrome. Okay. Diagnosis is salivary gland biopsy. Okay, salivary biopsy is the diagnosis, right? And this is nothing but the appearance of the anti-roller antibodies. These glands are involved, plus this test is we doing, it's called as Streamer's test. Okay, Streamer's test. So basically all the glands functions is reduced in Sjogren syndrome, right? So in Streamer's test, if it's positive, then you know that the glands function is not proper. Coming to the next topic, as we can see over here, the eyes are involved. There is some rash. Also, the rashes on the hand. Also, the joints are involved. Rashes are everywhere. Okay, and so this is nothing but the case of very important topic that is called as dermatomyositis. Okay, this rash is called as heliotropic rash. Okay, heliotropic rash is there. This is called as Gottron's papules. Okay, this is called as heliotropic rash. This is called as Gottron's papules. I'll just write down. heliotrope rash, Gottron's papilla. Okay. Apart from that, we have the shawl sign. That means inflammation on the back. Okay. And V sign at the neck. And this inflammation of the joint. This arthritis. Sorry, inflammation of the yeah, arthritis. Mild arthritis can also be there. Okay, so this is nothing but the diagnosis of dermatomyositis. Right. Coming to the one more disease over here, you can see oral ulcers are there. Here also genital ulcers are there. Here some erythema is there. Okay, I'll just label it as erythema nodosum and anterior uveitis is also there. So this is a diagnosis of your favorite Behcet's disease. Okay, Behcet's vasculitis or Behcet's disease. Right. Now coming to this case, we can see the ear are involved, nose is involved. Similarly over here, the nose is involved, nose is involved. So this is nothing but called as nasal chondritis. Okay, nasal chondritis. Here also auricular chondritis. And the condition is called as relapsing polychondritis. Relapsing polychondritis. All right. So this is about the rheumatology. Always remember whenever you're planning for any destination, you need a plan, a roadmap, and the courage. That's three equally important things. So recently, I went to the trek over at Hamta Pass, and we were exhausted like anything. And I thought, like, let's leave it. It was a 4 day tour trek, and second day was so difficult for me. Like I knew 2 days are left more, I should go back, but I'm not boasting about myself, but I did not any other options as well. We calculated, like for going back it needed 12 kilometers to go, and for going ahead it was like 7-8 kilometers, so better we go ahead only. So when you plan something, when you have some restrictions around you, that is called as Ulysses rule. So all these things we'll discuss in some later in a free time, but this is what you have to do whenever you're studying. Have a plan, have a proper roadmap, have a courage. Definitely, you will pass the destination, whatever your wish for. Thank you so much. Please let me know how you like the video. Thank you.